Hello, everyone. This is Yasmina Sisarak speaking. We are going to spend just a couple of minutes or a couple of seconds letting everyone in, and we will get started. I see people are logging in. I just want to give it a couple of seconds. All right, welcome to Promoting Brain Health Across the Lifespan for Individuals with Down Syndrome webinar. HealthMatters Program at the University of Illinois at Chicago and the National Down Syndrome Society have partnered to co-host the webinar. And the webinars will guide participants through ways to maintain brain health throughout life, emphasizing health promotion, strengths-based care, and the importance of supporting cognitive well-being. Today, we will examine common misconceptions about brain health in individuals with Down syndrome and understand why brain health conversations should begin early and continue across the lifespan. I want to introduce the two presenters today, Dana Shulo. Dana is the manager of health and wellness programs at the National Down Syndrome Society. She engages in outreach, education, and advocacy activities in support of NDSS's health programs. She's a licensed and registered occupational therapist with a background in pediatric care. And she also manages Scientific and Clinical Advisory Board, which is a group of researchers and medical professionals who advise NDSS on health-related initiatives. Also, today's presenter is Dr. Brian Chicoine. Dr. Brian Chicoine is the medical director at the Advocate Medical Group Adult Down Syndrome Center in Park Ridge, Illinois. He's on the faculty of the Family Medicine residency at Advocate Lutheran General Hospital. And in 1992, Dr. Chicoine co-founded the Adult Down Syndrome Center, which has served and documented the health and psychosocial needs of over 6,000 adolescents and adults with Down syndrome since its inception. Welcome. We are recording today's webinar. We will share the recording. Everyone on today's webinar will get a recording. We will email you once we put it in our YouTube channel. And welcome, Dr. Chicoine and Dana, and take it away. Oh, I'm sorry. Any questions that you have, please put in a question and answer box. We will hold the questions to the end, and we will have about 10 to 15 minutes for question and answer session. Thank you.
Hi, everyone. It's an honor to be speaking with you today. Thank you so much, Yasmina, for the introduction. As she said, my name is Dana Shulo, and I work at the National Down Syndrome Society. In addition to my professional role, I am also a sibling to Anthony, my brother, who has Down syndrome. Today, before Dr. Chicoine begins, I want to share a little bit about the work of the National Down Syndrome Society. Next slide, please. Founded in 1979, the National Down Syndrome Society, or NDSS, its mission is to create a world where individuals with Down syndrome thrive. Next slide, please. NDSS supports and advocates for the Down syndrome community through 4 primary areas of programming. The first area is resources and support, where we develop educational materials and provide direct support to families and professionals. Second area is research, where we work to increase the awareness of research opportunities and help ensure that individuals with Down syndrome are included in scientific studies and clinical trials. The third area is advocacy and public policy, where NDSS works to advance legislation and public policies that improve the lives of people with Down syndrome. And the fourth area is community engagement, which focuses on connecting and empowering the community through events, leadership programs, and awareness initiatives. Together, these 4 pillars help ensure that we are addressing the needs of the community from multiple angles. Next slide, please. One of the most direct ways that NDSS supports the community is through our resources and support services. We operate a 1-800 helpline and email service where families, self-advocates, educators, and healthcare professionals can reach out with questions at any time. In addition to answering these individual questions, NDSS also develops a range of educational materials. These resources cover topics across the lifespan, from diagnosis and early childhood to adulthood and aging. Topics include education, employment, health and wellness, caregiving, and independent living. All of these materials are freely available on our website, and we encourage families and professionals to explore the resources section whenever they are looking for reliable information. Next slide, please. NDSS's research programming develops tools, expands access, and creates opportunities for individuals with Down syndrome and their families to learn about and participate in the latest research and clinical trials. Through partnership with researchers, industry, and clinical trial teams, NDSS ensures that research studies and clinical trials are inclusive, accessible, and designed to reflect the real needs and experiences of people with Down syndrome and their families. Next slide, please. NDSS advocates at the federal, state, and local levels. We develop and improve laws to positively impact people with Down syndrome across the country and affirm their human rights. The legislative agenda spans the life experience of individuals with Down syndrome. NDSS also organizes the Down Syndrome Advocacy Conference in Washington, D.C., where self-advocates and family members meet directly with members of Congress to share their stories and advocate for policies that matter to the community. Advocacy efforts like these ensure that the voices of individuals with Down syndrome and their families are heard in the policy-making process. Next slide, please. One of NDSS's most recognizable programs is our National Buddy Walk, which takes place in communities across the country each year. These events bring families, advocates, and supporters together to celebrate individuals with Down syndrome, while also raising awareness and funds for local organizations. NDSS also leads initiatives like the Times Square video presentation, where individuals with Down syndrome from around the world are featured in large-scale awareness campaign in Times Square. In addition, we offer scholarships, run leadership programs such as our Athlete Ambassador Program and DS Ambassador Program, and we host a variety of events designed to build community and amplify the voices of individuals with Down syndrome. Next slide, please. Now I am honored to turn things over to Dr. Brian Chicoine. Yasmina already did a great job introducing him, so I will just turn it straight over. Welcome, Dr. Chicoine.
Thank you very much, Dana. What a pleasure to be here with you all today. I'm going to jump right in. So this is our center. We're in Park Ridge, Illinois, which is a northwest Chicago suburb. And as was mentioned, we opened in 1992. We opened when families were finding that their children were getting good care as kids, but not getting good care as adults. And so they came to the hospital at Lutheran General, where we're on the campus of, and asked that a clinic be started. And it started 2 mornings a month and just kept growing and growing. And as was mentioned, we've seen over 6,000 adolescents and adults with Down syndrome to date. Just a reminder, I have no financial disclosures, and just a reminder, this is an educational experience, not meant to replace healthcare with your health professional. So as you probably know, today people with Down syndrome are living longer and healthier lives than any other time in the past. I like to use this slide because it has 3 important dates. One is 1907. I do not have a sibling with Down syndrome or a child, but I did have a great uncle, Leo, who was born in 1907. He did pass away before I was born, but he was born in 1907 in central Illinois, and his life expectancy when he was born was only about 9. Interesting, Leo did live to be about 40, which almost certainly means he did not have congenital heart disease, which affects about 50% of people with Down syndrome. When I graduated from medical school in 1984, by then the life expectancy had increased to about 28. And then the last time data is available in the United States, it's zoomed up to about 60. Now this is for the white population of the United States. It's a little less for people of color in the States, and certainly less in some other countries where the medical care is not the same as we have here. And so that again, with about 50% of children having born with congenital heart disease, that impacts the ability to treat that has made a big difference in increased life expectancy. When Leo was born, about half the children with Down syndrome died before age of 2. Again, that was heavily to do with a congenital heart disease. So I want to just talk a little bit about a few definitions. I'll talk to you about just in just a second, just so that we're all sort of on the same page with what we're going to talk about after that. So dementia is a clinical syndrome characterized by chronic acquired loss of 2 or more cognitive abilities. It's caused by a brain disease or injury that is severe enough to interfere with daily functioning. And the cognitive impairment must represent a decline from a previous level of function. And that's particularly important when we're talking about people with an intellectual disability, because it's looking at where they started and then where the disease might progress, rather than an absolute level that perhaps they had never achieved. So it's really important to consider this as a change. So I like to think of dementia as sort of the broad category, and then Alzheimer's disease is one of the types of dementia. There are many types of dementia. And Alzheimer's disease is thought to be the most common type of dementia, with about a 42% lifetime risk in people without Down syndrome. But in people with Down syndrome, the lifetime risk is probably greater than 90%. In a study we did, the risk of Alzheimer's disease by age was 37 times more in people with Down syndrome. So particularly, not only does it occur at a more commonly, but also occurs at a younger age. And then again, Alzheimer's disease is if you look at the brains of people with Down syndrome, the brains of people with Alzheimer's disease under the microscope, you would see what are called amyloid plaques and neurofibrillary tangles, which are related to the tau protein. So again, Alzheimer's disease is much more common, but it is a subcategory of dementia. There we go. So another definition I think is important is just to look at early versus late onset of Alzheimer's disease. You might see those terms. And there's just by a standard, someone has decided that 65 years of age is the standard, from which if you're before 65, you're considered early onset. And if you're after 65, you're considered late onset. Nearly 100% of individuals with Down syndrome who develop Alzheimer's disease have early onset Alzheimer's disease. So almost 100% of people with Down syndrome who are going to develop Alzheimer's disease develop it before they reach the age of 65. And then 2 other terms, which I think are real important to appreciate, are what is called resistance and resilience. So resistance is the prevention, or the body's ability to prevent the development of Alzheimer's disease. And resilience is once the pathology is, once these plaques and tangles are there, what is the body able to fight off the onset of symptoms or delay the onset of symptoms? And so you'll see in a minute here why that's important. And then last sort of definition is the issue of brain health versus Alzheimer's disease prevention. So brain health would be considered optimizing the function of the brain, preventing age-related decline. And then Alzheimer's disease prevention or management would be just as it sounds like, you're actually preventing the development of Alzheimer's disease. So a question: will activities to improve or maintain brain health also prevent, delay, or lessen the effect of Alzheimer's disease? Again, going back to those definitions of resistance and resilience. At this time, we don't have research studies that clearly indicate we can delay or prevent Alzheimer's disease in people with Down syndrome. There are lots of studies going on, and so hopefully we'll have more information in the not too distant future. We do, however, have studies that demonstrate benefits of brain health in people with Down syndrome. So certainly, thinking about brain health early in life, certainly there's lots of information that shows that early intervention programs and cognitive training are the most evidence-based approaches for improving cognition in young children. Pharmacological interventions have shown limited or inconsistent benefits. We're not going to focus on that. In fact, I'm not going to say a whole lot about that. We're going to focus on as we go through life and what are the issues particularly with regards to brain health and Alzheimer's disease. So as I was going back and getting ready for this, I decided that probably the most helpful thing is to look at what we know in the non-Down syndrome population, and then look at what we know in the Down syndrome population. You will see as we go through this that certainly there's a lot more understood and known about what we know in the non-Down syndrome population, people without Down syndrome. And then the question will be over time, are we going to be able to take that information and assume that it's also true for people with Down syndrome? And we don't have the answer to that in many cases yet, but you'll see a little bit of information as we go forward. So some of it, we look at at this point, the information we know for the non-Down syndrome population, for the most part, makes good sense for health, but we don't know for sure what the implications for people with Down syndrome are in many cases. So let's first look at the genetics. Obviously, this is something we have less control over at this point. But we know that there's something called the ApoE4 gene, and those individuals that have that are more likely to get Alzheimer's disease. And there's also what's called an autosomal dominant Alzheimer's disease. There are 3 genes, and those individuals genetically are predisposed to getting Alzheimer's disease. And you can see, and you see that runs in family. This is clearly runs in families, and also it tends to happen at a younger age than Alzheimer's disease that most other people get. And then in Down syndrome, we know that people with Down syndrome have an extra 21st chromosome, and so on the 21st chromosome is a gene called the APP, or the amyloid protein precursor gene, and that gene is thought to have contribute to the development of Alzheimer's disease. And because people with Down syndrome have 3 of them, this triplication, that seems to increase their risk of getting Alzheimer's disease. So in those with mosaicism, in which not all the cells in the body have trisomy 21 or have the extra chromosome, possibly less effect, although that's less clear. But there is something called the critical region on the 21st chromosome. So you have to have this triplication of this particular critical region to be more susceptible to Alzheimer's disease. And it's in a handful of folks that don't have that critical region, they seem not to be not more likely to develop Alzheimer's disease. So the APP gene is in that critical region. So not having that gene in this handful of people with Down, otherwise, for all intents and purposes, have Down syndrome, they seem to not have this same risk of increased risk of Alzheimer's disease. So that's kind of an interesting thing, although there's not a huge number of people that would fit in that category. We really don't have good solid information on whether the ApoE4 gene contributes to more Alzheimer's disease in people with Down syndrome. So that's still being studied. And then interesting in people with, as far as gender, it looks like possibly younger women and older men with Down syndrome are more likely to get Alzheimer's. And that earlier menopause is believed to occur at a younger age in women with Down syndrome, and that may contribute to the onset in younger women. Interestingly, there has been no difference found in the average age of onset of individuals with mild, moderate, or severe or profound intellectual disability. So in a sense, where you start from, your level of intellectual disability does not seem to impact the average age of onset of Alzheimer's disease. And then the other genetic pieces, we know that people with Down syndrome genetically have more metabolic dysfunction and also have more inflammation in the body. And both of those probably contribute to Alzheimer's disease in some fashion, although that, again, that's more needs to be learned about that. So let's look at some of the things that obviously we can't control genetics, at least as today, but maybe in the future. But let's talk about the things we can control at this point. One is exercise. So in the non-Down syndrome population, we know that it reduces dementia risk. It improves cognition, especially in those with mild cognitive impairment. And aerobics and resistance training both have been shown to be beneficial. And if you're sedentary, you have a higher risk of Alzheimer's disease. So exercise does seem to have a significant protective effect against developing Alzheimer's disease and further impaired cognition. In the Down syndrome population, we don't have as much information, but there are some studies that show that people with Down syndrome do participate in less physical activity in general. So really, already folks are starting sort of a little behind the starting line there because they're tend not to exercise as much as other people. But it has been shown that in folks with Down syndrome, has been shown that moderate to vigorous exercise can be beneficial. Time spent in physical activity is associated with improved cognitive performance, reduced risk of decline of memory, and it may promote resilience. Again, going back to the definition, it doesn't prevent these individuals from developing the Alzheimer's disease pathology, but when they get the pathology, the effect may be delayed or less impact with the effect of the pathology on the clinical symptoms. So again, there's some positive information with that. There is unfortunately, no data to show resistance to Alzheimer's disease itself, unfortunately, at this point. And then another obviously gets a lot of discussion is the whole issue of diet. So again, looking at the non-Down syndrome population, we know that the DASH diet, which stands for Dietary Approaches to Stop Hypertension, seems to lower cognitive decline risk, seems to improve cognitive function, and seems to reduce hyperinsulinemia and inflammation. So going back to what we talked about, the genetics of people with Down syndrome, we know that the metabolic changes as hyperinsulinemia, increased insulin levels, causing difficulty managing sugar, and also inflammation in the body. This DASH diet does seem to improve those. So again, that would seem to make sense based on what we know about the contributors factors to Alzheimer's disease. There's also a couple other diets called the Mediterranean diet and the MIND diet, which also seem to help with these same benefits. So in general, if you don't know about these diets, in general, sort of a rough description of them there's a high consumption of vegetables and fruits and whole grains and fish and nuts and berries and olive oil, and then limited red and processed meats, saturated fats, and sugar-sweetened foods. And the other interesting thing is in the non-Down syndrome population is that weight loss seems to be associated with improved memory, obviously up to a point. But healthy weight loss seems to be associated with improved memory. In Down syndrome, we don't really have good information on what the effective diet is on both cognitive function, brain health, as well as Alzheimer's prevention potentially. But we do know, again, as I mentioned, Down syndrome is associated with more metabolic dysfunction, more insulin resistance, and more inflammation. And so, again, there's the potential there, as those studies hopefully will be done, that we would hopefully potentially even see more benefit because those problems are more significant in people with Down syndrome to start with. And then sleep is another important topic. In the non-Down syndrome population, we know there's what's called a U-shaped curve for sleep. So at the bottom of the U is the most benefit. How many hours of sleep does it take to best reduce your Alzheimer's risk? And so at the bottom of that U, it's been determined that's about 7 hours per night. And so going to the left, less hours of sleep, or to the right, more hours of sleep, neither one of those actually reduced the sleep effect, the disease risk, reducing the disease risk any more than the 7 hours. So from an Alzheimer's standpoint, lots of other recommendations on sleep, but from an Alzheimer's standpoint, at least in the studies that have been done so far, 7 hours seems to be the optimal. What do we know about people with Down syndrome? So the preliminary evidence links sleep disruption and obstructive sleep apnea with Alzheimer's disease-related pathology and symptomatology, meaning, for example, in those with sleep apnea, and again, sleep apnea is particularly obstructive in people with Down syndrome, meaning their brain is telling their body to breathe, but the airway gets occluded while they're breathing while sleeping. And so that actually disrupts the sleep cycle, but also reduces the oxygen in the body. And both of those things can have a detrimental effect on the brain. And so what we do know is that untreated sleep apnea or inadequately treated sleep apnea is associated with a greater amount of Alzheimer's disease pathology in the brain. And so, that certainly is wanting to address sleep apnea is an important thing. And also seems to be associated with more symptoms of Alzheimer's disease. So again, from both a resilience and a resistance standpoint, sleep apnea, treating sleep apnea and other sleep disruption is important. And again, not only sleep apnea, again, it's thought that perhaps 95% of people with Down syndrome may have sleep apnea. So not only is sleep apnea, but also the people with Down syndrome also have a lot of other sleep disruption, change in their cycles and whatnot. So again, these are important things to address. Unfortunately, there are not studies at this point that demonstrate treating sleep apnea prevents Alzheimer's disease. So it would make sense, but we just it's not been demonstrated. So although we know that having sleep apnea increases the pathology and the symptomatology, we don't yet know for sure that treating the sleep apnea will actually prevent those changes. So certainly more study needed in that area. And then social engagement. So in the non-Down syndrome population, it's been shown that social engagement is associated with a decreased dementia risk. So, interacting with others, participating in activities and all that thing with others is very important and does seem to decrease the dementia risk. What do we know about people with Down syndrome? So there is some data that suggests that social activity promoted resilience. So it didn't prevent the development of the pathology, but seemed to reduce the effect of the pathology in a sense that it reduced the progression of Alzheimer's disease symptoms, the more socially active people were. And so what one study showed was with an increase in amyloid over a 3-year period, as documented on a PET scan. So they're doing these scans that look at the amount of amyloid that's building up in the brain. And they followed this over 3 years. And so those that were had more social engagement, despite the fact having the same amount of amyloid building up, they had less effect on their memory impairment or memory performance than those people that were not as socially engaged. So very, again, another opportunity there to help with, again, not prevent Alzheimer's disease, but at least certainly increase the resilience against the symptoms. And what do we know about sensory? Certainly sensory, particularly vision and hearing, are so important. And we see so many, challenges, both psychological and physical, as people lose their hearing or their vision, and how much of a challenge that can be for them in general. But what is the impact on Alzheimer's disease and brain health? So again, in the non-Down syndrome population, we know that studies have shown that hearing impairment is associated with increased Alzheimer's disease risk. Now, there's some debate, is that because people become socially isolated because they have hearing impairment? What I found most recent thinking on this is that social isolation has a small contributing effect to the increased Alzheimer's disease risk due to hearing impairment. So hearing impairment can affect your ability to socialize, which does have some of the effect, but the bigger effect is actually the loss of hearing. And so, the ability to take in information, to process information, to process what our environment, to process what other people are saying, all of that, is part of the ways we maintain our brain health, and not having that or having that impaired actually seems to contribute to increased Alzheimer's disease risk. And similarly, vision impairment is associated with an increased risk of cognitive impairment and dementia. So again, loss or impairment of vision and hearing, certainly in the non-Down syndrome population, contributes to Alzheimer's disease risk, and that seems to be clear. In the Down syndrome population, sensory impairment, vision and hearing, is associated with cognitive behavioral impairments. We know that in people, even young individuals with Down syndrome, is if they lose their vision or hearing, how challenging that can be for them, both from a cognitive and behavioral standpoint. And there is some data that suggests it may increase vulnerability to a decline, to dementia. And so that's, again, more study needs to be done. If you're not getting the recurrent theme here, is that there's a lot of study that needs to be done in folks with Down syndrome to learn more about how we can address brain health as well as Alzheimer's prevention. Oops. Okay, so cardiovascular risk factors. So in the non-Down syndrome population, there's a sense that what is good for the heart is good for the brain. So what does that mean? So, we spend so much focus on, cholesterol and blood sugar and statin medications and all those things that are good for the vascular system of the heart. And the general sense is that as you're doing those things, not only are you benefiting your heart, that you're benefiting your brain as well. In observational studies, in people without Down syndrome, it suggests a protective effect, meaning if you're doing all those things that we typically think of as good for the heart, we may also be reducing our risk of Alzheimer's disease, of dementia. However, unfortunately, randomized controlled trials have not shown a clear benefit. So in other words, we see that those factors, high blood sugar, high cholesterol, not exercising, all those things are not good for the heart, seem to be not good for the brain, but correcting those things, unfortunately, has not panned out as far as showing a clear benefit to reducing the risk of Alzheimer's disease. Some of that may be, just the lack of the quality of the studies, but again, even in the non-Down syndrome population, that one needs more study. Now, the disconnect, I always find, is the disconnect in people with Down syndrome. We know that atherosclerosis being, it's been called hardening of the arteries in the past, or plaques, not the same plaques as are in the brain with amyloid, but plaques in the arteries, particularly going to the heart, but also in the neck going to the brain and other parts of the body, the vessels in the legs, etc. We know that atherosclerosis is less common in people with Down syndrome. So even with high cholesterols, high blood sugars, lack of activity, obesity, all those things that are risk factors in people with Down syndrome, just as they would be with anyone else. We don't see much smoking, but other than that, all those things that are more common. Presumably, people with Down syndrome have similar family histories as people without Down syndrome. But with all those factors, nevertheless, atherosclerosis is less common. So there does seem to be something about Down syndrome that is protective against atherosclerosis. We do know that a study that came out from, I think it was Sweden, in the last year or so, did demonstrate that people with Down syndrome can develop heart attacks and strokes, but it seems to be much less related to atherosclerosis than it does to other factors. And so, the most common cause of mortality in the United States being heart disease, with regards to the atherosclerosis, is much less of a common problem in people with Down syndrome than it is in other people. So in some ways, then, what is good for the heart is good for the brain doesn't quite make as much sense in people with Down syndrome as it does with other people. And there's been a little bit of look at, whether, for example, reducing cholesterol with statins in people with Down syndrome would reduce Alzheimer's disease. And really, there's not been adequate studies on this to really give us a sense of that. So we don't really know that taking a statin to reduce cholesterol, for example, is beneficial to reduce Alzheimer's disease. Really, again, the recurrent theme, more study needed on that to really get a better sense of that. And what about cognitive engagement? For those of you my age, you read a lot about, play this game, test your mind, et cetera, et cetera. What do we know? What do we really know about that? So in the non-Down syndrome population, engagement in adult literacy, creative art, and active and passive mental activities may reduce dementia risk later in life. And the benefit of cognitive training on cognitive function and executive function is pretty clear. So, taxing our brain helps improve our brain and also may reduce our dementia risk. What do we know about people with Down syndrome? So studies have shown that in people with Down syndrome, they had less cognitive decline over 16 to 20 months in those engaged in more complex employment. And this was ages 25 to 58. So people that had jobs that were more mentally taxing, that helped seem to maintain their level of function better than those that did not. Higher education employment is associated with better cognitive functioning in age range 29 to 67. And we had improved executive function within computerized cognitive training. So again, some of these additional means of trying to promote cognitive health were demonstrated to be beneficial. And then improved cognition and stabilization of function and behaviors when moved to a special care unit. This study was done in people that had dementia, and if you moved into the special unit, in this study that really promoted interaction and cognitive function, that actually seemed to slow down the decline that was associated with the dementia. And what are some possible other factors? So a study came out, actually this came out during the pandemic, which was really interesting. And I'll tell you why here in just a second, but psychological stress and depression in Down syndrome seems to be associated with a more rapid decline. So during the pandemic, we would see somebody that presented and they were declining more rapidly than I would necessarily anticipate. I mean, we see this at other times too, but it was really highlighted with all that was going on during the pandemic. But it was so these individuals were declining more rapidly than I would typically expect to see with someone with Alzheimer's disease. And so the question was, and so this made it much more challenging during the pandemic, for example. So we got the stress of not being able to leave the house, not being able to participate in your job, not interacting with your friends, the constant psychological stress that we were all under with the bombardment of the mortality count and the hospitalization information, all that stuff, as well as the grieving that was going on with the death of friends and family, and so all those things were happening at the same time. And so someone would present with this more rapid decline, and the question was, is this just, I don't want to say just, but is this a psychological response in depression, or is this they were already had sort of early symptoms of Alzheimer's disease, and this is just ramping up the pace? So that was that's anytime that's a challenge, but it was, we just saw it over and over during the pandemic because it was so common, unfortunately. So that seemed to be an important issue that does seem to contribute. So again, addressing stress and treating depression can be hopefully, we don't know that for sure, but also hopefully would then reduce the speed of decline. And then it's also known that something called late onset seizures, or LOMEDS, which stands for late onset myoclonic epilepsy and Down syndrome. Now, that's a mouthful. And what those are a type of seizures where there's sort of a jerking movements of the body. And those seem to be associated with a more rapid decline. Now, there is some question whether, if you treat those, will that reduce the rate of decline? Or is that just, do we tend to see those when the disease is already the person is already declining rapidly from Alzheimer's disease? At this point, the sense is different than in the past. The sense is we probably should be treating those more aggressively to not only make the person more comfortable, but also potentially to perhaps slow down the rapid decline. Again, not good data. We don't have good data to support that statement, but that is just a sort of a sense at this point. And then what about medications? So we do know that there's some newer medications like donanemab, which is an amyloid reducing monoclonal antibody. And what does that mean? So these are medications that actually remove amyloid from the brain. And they've been studied in, the number I've read is 17,000 people without Down syndrome. These medications were studied, and there was some modest slowing of cognitive and functional decline, obviously a reduced amyloid. But again, it was studied in 17,000 people without Down syndrome, but nobody with Down syndrome. And so there's a study, hopefully very soon to start with one of the drugs, donanemab, that hopefully will get a better sense in people with Down syndrome. Now, they are approved for people without Down syndrome. And so an obvious question would be, well, why don't we just treat people with Down syndrome? Unfortunately, one of the side effects of these medications, let me go back a step. There's something called amyloid angiopathy. And what that is as the amyloid builds up in the brain, that also builds up in the walls of the little blood vessels in the brain and damages these little blood vessels. And so they end up leaking. They have these little bleeding, these little hemorrhages. And that pathology, this amyloid angiopathy, is more common in people with Down syndrome with Alzheimer's disease than it is in other people with Alzheimer's disease. And so one of the questions would be, so we do know that these medications in the studies that have been done in people without Down syndrome, we do know that one of the side effects of these medications is increase of these little these little hemorrhages, it's little bleeds. And so the question would be, or the question is, if people with Down syndrome are treated with these medications, will they have more of these bleeds? And so there's a safety concern. And the other, from a benefit, from a treatment benefit, if they have a lot of these little bleeds, will that negate any of the benefit they get from being on the medication and reducing amyloid? And we just don't have that answer yet because people with Down syndrome haven't been studied. So hopefully in the next couple of years, I'll have a much better answer for this than I do today, because those studies are just about to start. So what are the thoughts on what we can do now? So I just like to, there's more studies needed, but what are, at least based on what we do know, particularly in the folks without Down syndrome, but also what we do about people with Down syndrome, what can we do today? So one is be more active. I mean, there are all sorts of reasons health-wise to be more active. Hopefully it's just more fun as well. But be more active is certainly important for brain health. Whether or not it ends up preventing Alzheimer's disease or delaying Alzheimer's disease to be determined, but we know that it benefits brain health nevertheless. Assess and modify the diet. Look at those diets. Is there things we can do to the diet today that would be more like those the diets that I described? Can we do something with our diet to try to help improve brain health, but also potentially to reduce Alzheimer's risk? Look at sleep, improve sleep, particularly test for and treat sleep apnea in people with Down syndrome. It's so common, and it is an option. And there are, the CPAP, which is the mask that blows positive pressure that opens up the airway for people with sleep apnea. You've probably seen that. Obviously, some people with Down syndrome, just like people without Down syndrome, have difficulty tolerating that. And so there are some other options now that you can look at as well. So even if you can't tolerate CPAP, there are some other options that hopefully can be tolerated and to use to treat sleep apnea. Assess for and treat sensory impairments. Years ago, there was a commercial, and a man and his wife were driving in the car, and the man, opened the window and asked the police officer for directions, and he gave the directions, and then he didn't hear it, and the wife told him what the policeman had said. So, and he didn't appreciate that they had a hearing impairment. So if people with normal cognition sometimes struggle with really understanding that their senses are impaired, how much more so is that an issue for people with Down syndrome and other intellectual disabilities? So really looking at how can we make sure that we're testing for these and screening people for these issues and treating them aggressively. Optimize use of cognitive and functional skills. So again, we know that we obviously don't want to put people in a job that they're just not capable of, because that could be overwhelming and very stressful, which has the potential, a negative potential. But how can we put people in a job that optimizes the use of their skills? In medicine, we call that, working up to the level of your license, meaning, go up to the level that, that you're capable of. And really, we want to encourage people with Down syndrome to do that as well, which has the impact for not only using their talents, but also to potentially improve their brain health and potentially even reduce Alzheimer's disease. Participate in social activities, get people out. I joke that if there's a person with Down syndrome that doesn't like to dance, I haven't met him or her yet. That's an exaggeration, but dancing is an activity many people with Down syndrome enjoy, and a great social activity as well as exercise. Beware of stress and try to address it to reduce the effect. And then we really need people to participate in research to improve our understanding of brain health and Alzheimer's disease prevention in individuals with Down syndrome. We just need to really understand this as well, and hopefully even better than we do for the rest of the population, hopefully in the coming years. So again, how do we support individuals with Down syndrome? How do we provide some of that support? So the picture on the upper left is our website, although in the next few days that's going to change. We're updating it, but we have a lot of information on Alzheimer's disease and brain health. The picture on the right there is the National Down Syndrome Society, where Dana works. Lots of good information on Alzheimer's disease, exercise, and other things. And of course, the HealthMatters Program, that we're talking with today. Oops, I keep clicking on that. This is a program that Dana and I were very involved in this is information for health professionals, although families and people with Down syndrome are using it as well, but it's written for particularly primary care clinicians. And so this is the Care Down Syndrome program, and it's got a 2-hour course that's got a list of articles on reference articles on a variety of topics, and each year we're going to be adding more articles and updating the ones we have. So please feel free to take a look at this. It's getting I would say a good reception. There's about 40 health professionals were involved in this project. So it's a broad variety of health professions that were involved in this, and so a lot of different information from a lot of different directions. So I encourage you to take a look at that. And again, if you need continuing education credit, it is that can be obtained for at least certainly for physicians. We're working on nurses, and other health professions can often just report it without having specific approval. And on that, you'll find again this 2-hour course, reference articles, and then there's a resource library. It really is information that health professionals then can share with families and people with Down syndrome, or people with Down syndrome and families can look at it themselves, of course. This is not restricted to use to health professionals, but that is the target audience. And this is the QR code and the webpage, and then the careds.org. Please feel free to take a look at that. And then if you're looking for some assistance more specifically for an individual, I'd encourage you to take a look at considering Project ECHO. And this is through the Down Syndrome Medical Interest Group. And in that, what we offer is, well, just a brief sideline. Project ECHO is something that started at the University of New Mexico around a health condition that has nothing to do with Down syndrome. And what they found is that the people with this condition in rural New Mexico were not getting to the university in a timely fashion. And so we're being treated much later in the course of the disease, obviously with less success in treatment. And so what they did is they started this Project ECHO where a health professional can sign up and then present a de-identified case. And then there's at least in our ECHO, there's usually 25 to 35 or 40 health professionals from a wide variety of disciplines, physicians, PTs, OTs, social work, psychology, et cetera, who are there to discuss the case and share information. It is de-identified. It is not open to families or people with Down syndrome because it's not medical care, it's an educational, but in a sense that the person that presents the case can take all that information shared by that panel of experts and then take that information back home in a sense and then treat the individual themselves. So good opportunity, and please feel free to take a look at that. And again, this one is from peds to adults. We've had OTs, PTs, psychologists, social workers, physicians, speech therapists. Really all comers are welcome to present. And again, if you'd like to find out more, here's the QR code. And then we have a list of references that you might find interesting. And then I'm going to stop, and we're going to, I think we have about 12 minutes left for a Q&A.
Thank you so much, Dr. Chicoine. There's a lot of questions coming through. First, I wanted to share our next webinar, and some of this is going to answer a couple of questions that already were there. We thinking about thoughts on what we can do now, optimizing function and preventing age-related changes in brain. We are going to be doing an additional webinar next week called Supporting Brain Health, Simple Strategies, Lifelong Impact. I will put the information for registration in the chat so you can even register. It's going to be recorded and shared, but it would be kind of building upon what Dr. Chicoine talked about today, the pillars of brain health, talking about physical activity, nutrition, social connections, and everything else that was covered. We will be together, HealthMatters Program and National Down Syndrome Society will be presenting practical strategies and talking about specific programs and apps and those kinds of things to kind of like build upon what Dr. Chicoine covered. Okay, I have tons of questions coming through, so I'm going to just keep asking them. What symptoms would we might see if our loved one begins to develop brain concerns?
So if you're talking Alzheimer's specifically, so certainly in people with Down syndrome, not all the studies, but most studies, or the majority of studies, find that psychological or behavioral changes are often the first symptom. Some studies show that memories is first. Certainly, those would be two of the common ones that would be common, that would be seen frequently. So we've seen a lot of change in personality and other things as early symptoms. A common thing I see is that say, oh no, he's fine, there's no problem, but then you go back and really listen, and the family is doing a lot more for the person, and so they're still functioning as well, but that's because they're getting a lot more support. Not that that's a bad thing, but that that's a hallmark that something's not right. So those would be some of the early things. Obviously, as the disease progresses, the loss of function in many ways, and ultimately, swallowing is loss of swallowing is commonly the thing that really ends up contributing to the person passing.
Is there a medical test to determine if there are plaques forming?
Yeah, Dana, you okay if I keep going?
Okay.
No, I'll go ahead and jump. Let me answer that. So yes, there are tests that there are what are called biomarkers, looking at blood tests, spinal fluid tests, and there's also PET scans. At this point, in people with Down syndrome, they're really more considered research tools than they are clinical tools, because we don't really have a good sense of those yet on how that should be used in clinical care. That information is hopefully coming rapidly, and particularly as we look to start introducing these other now that we're really hopefully going to have medications for Alzheimer's disease in the very near future for people with Down syndrome, I think that's going to be that much more important to support the diagnosis with these biomarkers, as well as neuropsych testing and other testing. But so the short answer to the question is, some people are using them in people with Down syndrome, but our sense is that let's hold off until we get a little more information so we have a better sense of what they mean in people with Down syndrome versus in people without Down syndrome, where those tests are being used at this point.
At what age do symptoms appear typically?
So it's commonly not before 40. So it's uncommon before 40, but certainly people in their 40s and 50s. Average age of onset is thought to be about 53. And I did see a question pop up while we're talking about that. How long is the course of Alzheimer's in someone with Down syndrome? So the average age of death from Alzheimer's is typically about 5 or 6 years after the onset. That's longer in people without Down syndrome, and certainly longer in some people with Down syndrome, but that is an average.
Do you find that dementia onslaught is accompanied by seizures?
That's a great question. So seizures are, so if you look at people with Down syndrome, certainly seizures are more common in people with Down syndrome in general. But if you look at the seizure onset in young, childhood, you see a bump up. You see more seizures develop in people with Down syndrome in childhood. Certainly throughout their life, they can develop seizures. But the second bump is later in life, and that's associated with Alzheimer's disease. I have seen people that the first symptom, there was no other symptoms of Alzheimer's disease, and they developed seizures. And then within the coming months or year or so, they actually developed other symptoms of Alzheimer's disease. So I suspected that was actually the first symptom in some people. But seizures are very common, much more commonly associated with Alzheimer's disease in people with Down syndrome than in other people who don't have Down syndrome, who can develop seizures with Alzheimer's disease, but nowhere near as commonly as people with Down syndrome.
There's a couple of questions about vitamin use and types of vitamins to prevent onset. And also, I'm going to kind of combine a couple of these. Do you feel taking turmeric would be beneficial to reduce inflammation, since it seems to be common?
Yeah, I think that, again, that's similar to what, a lot of the information we shared is that, we can look at what people are doing in people without Down syndrome and wonder if it does benefit people with Down syndrome. again, unfortunately, we just don't have the data to tell us for sure that we should or should not be doing that in people with Down syndrome, unfortunately. So hopefully that's coming, but not here yet.
Have there been any studies that looked at people with Down syndrome who lived past 60 and not developed Alzheimer's?
Yeah, and so I did mention those few people that didn't have that critical piece at the 21st chromosome, so that extra 21st chromosome. So those people, but there are some other studies that look at, and there is a small number of people older in life, past 60, that don't develop Alzheimer's disease. So not enough data on those folks, but certainly a lot of interest in presumably those folks have neuropathology, because basically everybody over the age of 40 with Down syndrome has the neuropathology. So why did they not develop clinical symptoms? And that's that whole resilience question, and much more study needed on that.
I understand that GLP-1s can reduce some chronic inflammation. Are they safe to take for a 27-year-old son with Down syndrome? He's otherwise healthy, but of course overweight and has sleep apnea.
Yeah, so great question. Certainly, some of the physicians in our office, we're prescribing some GLP-1s for some of our patients, and certainly there's others across the country that are doing that as well. Lack of good general information on GLP-1s in people with Down syndrome, although most people feel like they're pretty safe in people with Down syndrome. But again, not a lot of good study in people with Down syndrome on the GLP-1s. The one concern I have is that we know that there are studies in the non-Down syndrome population that show that muscle mass loss is greater with the weight loss related to GLP-1s than it is with weight loss related to diet and exercise. And so, what is the impact on people with Down syndrome who already have low muscle tone typically, and laxity in their joints? That is a theoretical concern. I don't have any data that tells me for sure that's really a concern, but it is. I do have that concern.
What tests can be done to distinguish the difference between Alzheimer's versus Down syndrome regression disorder? Given the emergence of DSRD, do we think that early Alzheimer's has been confused or overdiagnosed in Down syndrome individuals versus DSRD? I'm sorry.
Yeah, I say I've gotten calls from all over the world and people saying my 20-year-old with Down syndrome has Alzheimer's disease, or he's been diagnosed with Alzheimer's disease. I suspect a lot of those were Down syndrome regression disorder or other conditions. I've learned never to say never in medicine, because as soon as you get cocky, say never, you're going to see the one case. But a 20-year-old with Down syndrome having Alzheimer's disease, it would be almost a never. And so, yes, I think some of those folks, when they were younger, were misdiagnosed. Down syndrome regression disorder is typically more rapid onset, is typically younger. So 15 to 25, versus more than 40 for Alzheimer's disease in people with Down syndrome. A study just came out just in the last couple of weeks that suggested that people with Down syndrome regression disorder had this is a different pathology than Alzheimer's disease. So they did look at the brains, and so that they were not finding that the people with Down syndrome regression disorder had more plaques and tangles or anything that would suggest that this is an early manifestation of Alzheimer's disease. So it seemed to be, at this point, they seem to be two distinct entities.
Thank you. Is it true that older Black persons with Down syndrome are twice as likely to have Alzheimer's? Were the findings of bleeding in the brain similar across all demographics?
I have not heard that, and it would be hard to say someone has twice the rate since about 95% of people have it in general. I mean, so it's so common. If there's an increase in Black individuals, it certainly couldn't be twice, because you can't have twice times 95%. But I'm not seeing anything that this clearly states that it's more common in people with Black people. Have you seen that, Dana? I haven't seen that. No.
I will combine two questions. Do general PCPs have and use this knowledge? And then what type of professional would be suggested to consult if you wanted to have your child tested for any type of dementia, and what type of tests would be required?
So part of the reason we developed the Care Down Syndrome program was because many primary care physicians don't have the knowledge. And so we really wanted to get information into the hands of the primary care physicians out in the community. A study done by Stephanie Santoro at Mass General several years ago found that the Down syndrome clinics really only have capacity to serve about 5% of adults with Down syndrome in the United States. So the other 95% are cared for by, primary care physicians in the community. And so that's really what the Care Down syndrome, how do we get the information to that 95%? So if you're one of those folks that are concerned that your primary care physician doesn't have the information, please share that information with them. And so in the Down syndrome, in the Care Down syndrome, and you can find information on, here's the general test that we recommend for testing for Alzheimer's disease. And then again, a neurologist certainly would be someone to think about consulting with. But again, if there's a concern about sleep apnea, treating the sleep apnea, the concern about depression, either the primary care physician or psychiatrist treating that. So really kind of depends on what the workup shows on what direction to go. We, although this will change somewhat as the biomarkers continue to get sorted out. Alzheimer's is still a diagnosis of exclusion, meaning you really have to look for all the other possible reasons that someone can decline and rule them out and or treat them. There's a pattern of Alzheimer's disease, but there are so many things that can cause people to decline. We really want to make sure we're addressing those before we jump to this conclusion that it's Alzheimer's disease.
Well, thank you so much. We're at the hour, past the hour. I'm very sorry if I did not get to the questions in the audience. Thank you to the speakers. Please, Dana or Dr. Chicoine, if there are any follow-up questions, Dana, there is 1-800 number. Could you please put it in for NDSS? So if anyone feels like they need to follow up, you can use their 1-800 number or the info email. We will share the recording shortly. Thank you all for coming. Thank you to the presenters. This was wonderful. And hopefully some of you can attend or just register for next week's webinar, and hopefully you can get additional information for brain health promotion. Thank you and have a great rest of the day.
Thanks for inviting us.
Thank you. Bye.